And welcome to another edition of The Big Q. Rwanda is set to host ICASA. Well, we will be telling you exactly what ICASA is and where we are standing when it comes to HIV prevalence rate in our country, Rwanda. And that's why I'm joined by Dr. Sabe Nsanzimana, who is the Director General of the Rwanda Biomedical Center, to take us through. Welcome to the show, sir.
Thank you. Thank you for having me.
So ICASA, before we dive into ICASA, maybe we start off with where we are as a country when it comes to the HIV prevalence rate.
Thank you very much. When we talk about HIV situation in a country, we're talking about like 5 numbers. Number 1 is the prevalence of HIV in the nation, like how many people have the disease out of the total population. So we recently concluded a study. The data were released last month. And we found that actually the prevalence we've been talking about, 3% of Rwandese living with HIV has changed slightly to 2.6% from 15 to 49 years old people. But we also observe that people are aging with the epidemic. So if you expand the age from 15 to 64, you get the 3% we've been talking about before in the previous surveys. Number 2, we are talking about the new people who are infected, who were not infected before, but this time are getting HIV. So, and we measure this annually. So the data we have suggesting that we are getting actually 1 per 1,000 people infected on annual basis.
1 per 1,000?
Yeah, 1 per 1,000. In terms of absolute numbers, you're talking about 5,400 people per year.
Okay.
It's a big number if you think about where we came from and where we are, but also it's an interesting change because 5 years ago we were talking about 10, 12,000 people per year were newly infected. Now moving from 12,000 to 5,000, it's more than 50% reduction, but it's not enough. Maybe I would talk about a figure number 3, just to understand the situation of the HIV epidemic. There are people who are newly infected, there are those who have the disease, there are those who are actually exiting for reasons including death. So we measured also mortality for people who are HIV infected. So we count around 3,000, between 3,000 and 4,000 people who are dying due to AIDS-related diseases. And this, again, is it's a big number compared to the people who should be living with the disease. But again, comparing to where we came from, it's 82% reduction over the last 10 years, which is also an interesting shift. Whatever you can do, you have people exiting. This is a normal epidemiological shift of Fontaine. But you don't want people to die for disease that you can prevent. So antiretrovirals have helped to maintain people longer, and life expectancy in Rwanda now has achieved an interesting number. 67% of people can live in Rwanda on average, including people living HIV are actually also living longer than before. For women and girls, for example, the life expectancy is almost similar to the normal. People are not infected. For men, it's quite low. Actually, men are not doing well in this HIV programming for reasons maybe we can discuss in details. But in general, those are the key figures. Plus, in prevention, I would say that mother-to-child transmission is also important. So before we're getting like 10% of children getting HIV from their parents. So today we have 1.5%, and the aim is to get to 0. Because with the drugs, with the tools we have, we can prevent that. Maybe another key indicator is the community perspective, or how they appreciate the programs, and how it helps the other sectors like economy, like the well-being, like other associated diseases like tuberculosis, like meningitis. All those diseases actually, some of them are disappearing due to HIV control in general. Like cancer, some cancer, like an example is called Kaposi. For example, you could see people who were infected like 10 years ago, would see the skin changing, the colors. You'd see somewhere in their faces, see one face has a color, another one. Those are the types of cancers that were happening because people were delayed to be treated. So today, you can spend 5 years trying to find a kaposi and you never see it. So those are the things, the change that happened because efforts were made by different people, different programs to control HIV.
But of course, with all that, we have seen that urban places, say Kigali city, of course, through the survey that you launched recently, it indicated that Kigali, at least, is at 4.3%.
Right.
You know, how do we deal with this? How do we ensure, as much as Kigali might be holding a bit of the economy, but then again, we want people to be safer and, you know, more healthier. How do we deal with this?
Yeah, you're right. It's not only Kigali, it's actually all urban settings. If you go in other provinces, like the centers, the cities, you always have higher prevalence than than rural areas. And this goes with the people behaviors and living conditions, plus the sex work activities that goes with that. So, for example, in our research, we found that almost half of the sex workers are HIV infected.
Half?
Half, 50%.
Wow.
Yeah, it's huge. We did the survey twice, and all the 2 times, actually, before it was even higher than 50%. And they operate mainly in the cities, in urban settings. In Kigali, you can actually, there are some areas where named due to those sexual activities are happening. They go all along with bars and the hotels and some hotspots. So that is probably the explanation to link Kigali and the other major cities with HIV infection rates. And we believe that by controlling infection in those key populations, you can impact on general population overall prevalence. So, unfortunately, Kigali has the highest rate at the moment compared to other provinces, 4.3 versus 2.9.
Yeah.
But Kigali came from 6.3. Actually, it's a reduction.
So it's a reduction
of 2% in just 5 years. This is also impressive.
Yes.
Yeah.
Rate of new infections versus old. Where are we right now? How quickly are people infected compared to the old, you know, infections that were there before? So
I think the data we have enough to give us like interpretation that we are getting less and less new infections. And actually people are getting, they protect themselves now than before. The use of condom, for example, the treatment is actually a prevention as well. So, for example, if you treat 10 people, you prevent infection to 6 other people. Because the virus that is in someone's body explains the risks or probabilities to transmit to the others. So the more people are treated successfully, predicts the people who will be protected to get infections with numbers. Out of 100 people in Rwanda, 67% have reached the levels of not transmitting at the rate of 96%. So which means the 24% remaining who are not suppressing the virus are the one at high risk to transmit the virus, which is good in an epidemiology perspective. You don't want to treat individuals, you're treating communities. So if you count the amount of viruses in the country, you can contain them on treatment, you will not get people infected, even if the behaviors may not necessarily change. But you don't forget to add other tools like condoms, educations, awareness. Those can have a contribution, but we've seen with biomedical prevention, like treatment, like circumcisions, like condoms, those ones work faster and better than having messages or talking to people. We've spent millions of dollars on that, but the changes are not that big. That's why people always have been telling me in my 10 years in the HIV program, now your awareness has dropped. I would say, yes, I agree.
And I wanted to pinpoint that, of course it has dropped.
I was expecting that question. But the results has improved significantly.
That means you're comfortable then, are we?
Very comfortable. I mean, not comfortable because we have 5,000 people are infected. But the shift we've made in 2010 from a massive awareness and less of biomedical to, we are now doing like 70% biomedical and 30% awareness, general messaging, because we see quick results by doing these circumcisions, treatment, particularly treatment, and going directly where the problem is. It's like focused interventions. But before, we were like printing books, messages, banners on the streets, no one's reading it.
Everywhere.
And a lot of money is used on that. And now we're trying to be a little bit focused. And the more data we get, the more precisions into our interventions. And we see results on a daily basis.
Biological changes are among the factors that can also put sexually active women aged 50 years and older to be at a high risk of acquiring, HIV. Has RBC taken strategic actions to prevent HIV for this particular group that reflects to the key needs of the population?
Yeah, to me, that's the biggest challenge we have. The young people, 15 to 24 years old, both in testing, they're not doing well as older people. Treatment, the ones that drop medicine more compared to adults, and also other kind of behavior and shifts from childhood to adolescence and other cascade of care processes. I would say that this is the next huge focus for the program to look into. And now that we are seeing reports and increase in unplanned and unwanted pregnancies, it predicts also the HIV risks and also sexually transmitted infections, diseases. And my conclusion is that the programs we've been planning or setting in place were not necessarily adapted to different ages. We've considered the general populations as one.
As one, yeah.
Yet we have, now it's time to focus in subgroups. It's the same, like messaging, keep message to everyone. Maybe it works for 10%.
Yeah.
But focusing on those groups is key. And also which groups and what they need. I was telling colleagues at HIV program before that if you print books, maybe people 50 years and above will be interested to read something printed. Maybe 15 years or 20, they may want an application on their smartphones or something that is fun, that is live. So we're adapting all those messages and programs, even treatment. If you give 5 pills a day to an adolescent who wants to go to enjoy with friends in boarding schools, doesn't work.
It doesn't.
Maybe 1 pill that is simple, easy to carry in a pocket. So, I mean, I agree with you. It's a serious gap, and we're working on it.
Let's talk about another community, the LGBT. This is a community that I have had the privilege of talking to, and they will tell you when I go to hospital, it's very sad because doctors, treat me differently. Before I even try to know my, my status, they try to explain, but they're already laughing at me, How do you deal with these issues? Because I believe they're also part and parcel of the community, but then how do we make them feel comfortable, but also treat them in the right way?
So I look at it into perspective of health in general. I talked about the risks to get HIV, different groups. So key populations, LGBT communities, for us has been a group that has been severely affected by HIV, due to how sexual activities are conducted in those groups, by how the community accepts or rejects some of them, and also other factors such as drug use. Sometimes when they are mistreated, they may end up being into other behaviors. So we look into that, and our program since the beginning, 4-5, has been always focusing on those groups to make sure they get proper preventions, proper treatments, and we've seen results. Sex workers is a group among those. So in the beginning, we're seeing men being infected from sex workers. They go home, they infect their families, mothers and children to come, and then they connect through the community. They become a general population issue. Same for men having sex with men. Before we're saying, no, we don't have these groups, we try to close the eyes, but the reality is different. You have to accept the reality and try to deal with the problems that can affect the health of the communities, rather than focusing on issues that are even beyond the health. So For us, in our research, men having sex with men also is a part of the groups that is affected. Why? Like sexual activities, the way they conduct sexual activities, we put them at risk 10 times more than the usual heterosexual ways of doing sexual intercourses. So our diagnosis has been, let's work on this group, make sure they don't be a bridge to continue to spread HIV, and we protect the general community and them, because they're also part of the communities. So now we see that it has worked, but not enough.
Not enough, yeah. But Dr. Sabe, let's talk about the condom dispensers. I know you will tell me that we have condom kiosks, you know, across the city and maybe across the country. But these condom, you know, dispensers, we used to have them in hotels. We used to have them in hospitals, you know. We used to have them in private, you know, public but private areas, you know, at the same time. But we no longer see this. Is this, you know, part and parcel of the progress of increased, the small number that is, you know, that is increasing? Maybe if we had this still, it would work. Do you think so?
Yeah. Condoms is a very complex program. I had to learn about this during my experience, that it's not just simple condom and distribution. It's complex in a way that, for example, in Rwanda, we distribute more than 20 millions of condoms a year.
20 million?
More than 20.
Wow, okay.
In 1 year. And of those, 15 millions are through the shops, through the social marketing channels, and only 5 or more through the other channels, like the kiosks, like the machines we used to have, like community health workers distributes, health facilities, sex workers, networks, they distribute condom themselves in public. The portion you're talking about is very, very small. Most of the condoms across the country are through these kiosks, small kiosks in the quartier. But it's not enough. If you go in a village far where there's no boutiques, you get issues. I've had youth calling and asking. We've tried to increase or to invent new channels of distribution of condoms. But it is a progress that we have to improve as well. Now, to your question on the kiosks or dispensing machines, we used to have in 2007, 2008, and they stopped. Why these machines stopped? One, misuse of the machines, and there was no return on investments, if I can say it that way. These machines are quite expensive.
They are, yeah.
And you would see someone just going after taking like 2 drinks and wants a condoms or money to pay the drink, just go in behind where the machine are located in a private, then they just break the glass of the machines and pick both the condoms and the coins that are inside. We've seen that across the country. Then after all, most of the machines are broken. They say, should we replace them the same way or should we do something new and more cost effective? And for us, although they were useful in a few people attending hotels, it was not reaching so many people and where the problems are. That's how the idea of condom kiosks came in. And they said, we have people who need condoms and don't access condoms. And they have 50% of HIV prevalence. Those are sex workers. Where are they? Their clients are always with where they are their clients. And they have always bars and people drinking around. Those are the hotspots we mapped across the country. And we worked with our partners. The city of Kigali actually was the champion to establish those kiosks as a pilot to see if this idea can work.
Absolutely.
Yeah.
Well, we do take a short break, but when we come back, of course, we're still talking to Dr. Sabe, and he will be telling us now what ICASA will be doing in the country and what it means for us to be actually hosting this. Do keep it the big Q. Welcome back, and thank you very much for keeping it the big Q. Of course, I'm still with the Director General of the Rwanda Biomedical Center, Dr. Sabe Nsanzimana. And before we went for a short break, we were talking about the dispensing of condoms, but now I want us to jump straight to ICASA. What is ICASA, and why are we hosting it? And what does it mean for us to even host such a big conference?
Thank you. So ICASA is the largest conference on AIDS in Africa, actually among the largest conference in the world. ICASA is an international conference on AIDS and sexual transmitted infections in Africa, but it brings the entire world to the country that is hosting. So expect, for example, in Rwanda, 150 countries that may be attending. So this conference is 20 years old. It has been happening across different countries. Actually, the first one took place in Europe, in Belgium. Then it was shifted to Africa. That's where HIV is. More than 70% of the HIV burden is in Africa. So we've been trying to host this conference through competitions. And then we were selected in 2017, and we were given this opportunity to bring these people to Rwanda. So in the vision and the direction of Rwanda becoming the hub where people come, meet and enjoy, and also share the science and the experiences, that's how we came to get ICASA. And to get ICASA was not easy, but infrastructure-wise, program-wise, the cleanliness, security, safety, there's several criteria that we had to go through to be approved. And it was quite straightforward, because having the convention center, having the program, having all I mentioned, and Kigali is a city now that has a set of clean, green, and safe. It was a good platform to have this conference coming in a few days.
But what should we expect from this? Because it's one thing to have a conference, and it's another thing for it to actually implement things that affect the citizens and the communities.
So the main thing we expect from this conference, of course, from perspective of a health expert, is to know more, or to learn more and share. Having a huge number of experts coming, the people who've been meeting just in a few minutes now, they'll be coming for a week. You can exchange, they connect to us, and there are new developments in HIV programming that will be shared. I give an example of treatments. There are new ways of treatment that is going to be displayed or presented here. There are new guidelines, new evidence. And not only HIV, other diseases, tuberculosis, malaria, and we talk about Ebola as well during this conference. Second is the economic benefits to the country. So we were looking at the rooms to host the people, and it was always good to see how hotels around, we get guests. Whenever you see someone, it's always a good learning process. Our private sector federation for sure will benefit from that. And also looking at the community connections. So there's huge benefit to host such a big conference. Expect 7,000 to 10,000 people in a country. We've never seen this before. And is setting also a ground and a platform that we are capable to host huge events. So if we successfully host ICASA, and we will, for sure we will get more big conferences, and our capacity will keep increasing and our standards go up.
Now back to your program. Of course, through this you've mentioned that there are new ways of treatment. We've also mentioned the way taking 5 pills in a day is difficult. Where are we as a country today in the newest or easiest form of treatment that you have for the patients?
So that's a good question. I remember when I joined the program more than 10 years ago, we had to give 12 pills to the patients. They were actually joking whenever I give them pills, give me a spoon so that I can eat the pills. And it was very hard with a lot of side effects. The patients, some dropping, some forgetting. It was very bad, that time. But we shifted from 12 to 8 pills to 4 pills. Now we're at 1 pill a day. 1 pill with less side effects, taken in the evening. Then someone can live his or her normal life as anyone else. So has been a tremendous improvements. So now the discussion is shifting from 1 pill a day to an injection that can last for weeks or months. So there's one advanced treatment with an injection for 8 weeks, with 2 antiretrovirals combined into one. Then someone can get another injection after 8 weeks.
Is it affordable?
It's still under last phase of development. It's actually now almost advanced. Soon we may get this on the market. It's being tried, it's being tested. We've been part of this research and discussions over the last 5 years. And this is quite interesting. But someone will tell you, oh, an injection every 2 months. I prefer my daily pills. Then there are also ideas of other options. This framework has been named a long-acting treatment or long-acting technologies, not only to HIV, for other chronic diseases. Like family planning methods. You have an implant or you have a plastic. I mean, let's call it a way of transforming the treatment into a form that can last longer. Let's say an implant into your arm, then can last for several months. Or maybe a capsule you can swallow and remains in your stomach for several months. Or even some other micro needles you can have on your skin with drugs inside, then it can remain. So these technologies are being developed. And during this conference, we'll host one event co-organized by Ministry of Health and Rwanda Biomedical Center with UNITAID and the World Health Organization. It's on the 3rd of December. So we will discuss all these new technologies. And how Rwanda can position itself among the researchers who are developing this. So I actually see this coming soon as a new ways of handling HIV treatment better and safer, and encouraging those who are not yet tested. Getting an injection for 6 months will be fun.
Methods of testing, Dr. Sabe. You know, there are people here now, you can swap. We don't have to inject to get the blood. How, what forms of testing do we have now, and how efficient are they?
Yeah, again, I come from the history. When I was in medical school, I remember you had, near my village, there was a testing site, but there was no testing as such. You're drawing blood, sent to Kigali. Kigali, they test. Then a few months, they bring the results. Sometimes you wait and you forget. No one is aware of the status. And that was not a long time ago. But we shifted from that into going the same day, you get the same result. To 20 minutes, you test it at the facility, you get the result. Today, you can test yourself. You can buy a self-test kit in different pharmacies. It costs 4,000 francs. And it's oral. Oral, you don't need to use your blood. You just, as you demonstrated, it's quick. And you can do it in privacy. And you go home, you buy it, you test yourself, and you decide. People are saying, oh, people will commit suicide.
Exactly, the trauma. I'm trying to think of the trauma. No?
Yeah, we've been implementing this for the past 3 years, and we didn't record any single case. Even, it's not called suicide, even a case of depression. No, actually it helped people to accept and to make decisions.
Before.
Because they've been always thinking, maybe. So you decide, if you are positive, with a probability of maybe 1%, you would go for treatment, and you take your pills, no change on your life, you continue. If you're negative, you're good. You take the, oh, okay, now I'm going to behave this way. Self-testing is really good.
As we sum up, Dr. Sebe, maybe I'd want you to make a call to the population or to our viewers who are watching you, be it in terms of taking medicine, be it in terms of testing. What would be your call for them as we sum up?
So maybe 2 messages. For the youth, for young people, HIV is still there. And we want you to not have HIV, and not only HIV, but related diseases. So because the future is better. Future of diseases or all these constraints, probably this is not what we wish for the youth. So please protect yourself. You have tools, you have all you can to make sure you remain who you are today. And if you are infected, the life also continue. Life continue. We have services, trust in our services, and you live longer and better. and you can also advise and teach your fellow brothers and sisters. For older people, HIV is not for young people. Actually, more HIVs for older people.
Yes.
Now we see people aging 80, 90 years with HIV. Wow. We have them. So it means that people contract the virus 10 years, 20, 30 years ago, and they're living with the virus. So we tell them, yeah, you can keep living, enjoying your life, but not transmitting the disease or the virus to the young ones. So maybe those are the two key messages I can say at the moment. And we want to end AIDS by 2030. We can only do it if whoever has the virus is tested. If not, the virus will develop, then we will see people dying. The 3,000 we're seeing mostly are the ones coming at the last minute.
Absolutely. Well, thank you very much, Dr. Sabe, for making time to be with us.
Thank you too.
Of course, I've been talking to the Director General of the Rwanda Biomedical Center, Dr. Sabe Nsanzimana, and he says, even if you have AIDS, you can still live with it, you know, and there's a future for you out there. So don't keep it the big Q. My name is Fiona Mbabazit. Keep enjoying the rest of our programming.